Hello, everyone, and thank you all for attending today. My name is Nicole Jarvis. I'm the Assistant Director of Programs at Cancer and Careers, and I'll also be today's webinar host. So before we begin, just a few housekeeping items related to accreditation. Let me just get this slide going. Today's webinar is accredited for CEUs by ANCC, NASW, the New York State Education Department State Board for Social Work, the California Board of Registered Nursing, and the Society for Human Resource Management. If you plan on receiving credit for this program or a general certificate, please proceed with the following steps. First, you must log in individually. Participants who listen in on someone else's line will not receive credit. Second, you must complete and submit the evaluation and post-test, as well as receive a passing grade on the post-test. You will have the opportunity to retake that test if you don't pass the first time. Following today's session, you will receive an email with all of this information, and that email will be sent by 5 p.m. Eastern Time tomorrow, which is Thursday, October 14th, and certificates will be emailed within 4 to 6 weeks. Also, please note that the planners and presenters for this program have not disclosed any pertinent financial relationships or conflicts of interest, and that no commercial support was provided for this program. Thanks in part to direct support from Genentech, HSN, and QVC, Cancer and Careers is able to offer this 7th year of the Balancing Work and Cancer webinar series. This program was created to provide patients and survivors, as well as their healthcare teams and employers, with concise, targeted information around the work-related issues that arise after a cancer diagnosis. Additionally, we'd like to recognize Cancer and Careers year-round sponsors who support all of our core programs and allow us to continue providing all of our resources and services free of charge. So, as we all know, health insurance is an extremely important piece of the employment conversation. Unfortunately, it can also be very confusing when trying to understand the various options and existing policies, particularly in the midst of dealing with a cancer diagnosis. I'm thrilled today to introduce our presenter, Monica Bryant, who will explain the very complex issue clearly for us all. Monica is a cancer rights attorney and the COO of Triage Cancer, a national nonprofit organization dedicated to providing education and resources on cancer survivorship. She has been a longtime collaborator with Cancer and Careers and is extremely skilled at taking complex legal and insurance issues and making them that much easier to understand. So thank you, Monica, for being here today, and I will hand it over to you now.
Thanks so much, Nicole. I am delighted to be here today to talk about health insurance. In this session today, we're going to cover the consumer protections that we all have as consumers of healthcare. We're going to talk about various health insurance options that are available. We're going to talk about if you have multiple options available to you, how do you go about actually making choices between those options? Then we're going to talk about some potential changes and advocacy opportunities. Now, when we talk about health insurance, it is tied to finances. And over the last couple of years, there has been a buzz term in the cancer community of financial toxicity. And this was really a term that was coined in 2013 by researchers out of Duke University. And in their research, they focused on how the financial impact of a cancer diagnosis can have a similar impact or burden that the physical toxicity of cancer treatment can as well. And what was particularly interesting about this research was that they didn't just focus on how it impacts somebody's bank account, but they also looked at how the financial burden can really impact somebody's overall quality of life, not just in an acute way during active treatment, but also how it has a long-term impact. So that was in 2013, yet here we are still talking about it in 2021. And one of the reasons why that is that there are multiple contributing factors to financial toxicity. And we're talking about it today because the number one most significant contributing factor to financial toxicity is health insurance status. And certainly that could mean not having health insurance at all. But what we see at Triage Cancer is that more often it's about having inadequate health insurance for that person's situation, or not effectively using the health insurance policy that they have. So we're going to obviously spend most of today talking about that. Certainly the employment changes that can occur after a cancer diagnosis can impact somebody's finances. And then all of the things that normally impact our finances in life, like moving and relationship changes and graduating, can continue to occur after a cancer diagnosis. And so Triage Cancer has a checklist to avoid financial toxicity that includes many of the questions that can be asked of individuals to help them avoid this financial burden, or if not avoid entirely, at least minimize it. I fully recognize this is tiny to read on your screen, and I apologize for that. But if you go to the link at the bottom of the screen, you can see the full-size version of this document, and you'll see it has several questions around health insurance. Now, when you download the full-size version of this document, on the left-hand side, you'll see all these questions. And on the right-hand side, you'll see all of the resources that we have at Triage Cancer to help people address the answers to those questions. Because although we're going to spend an hour today talking with each other, it's really just going to scratch the surface. And we want you to know where you can go after today's session to get more in-depth information about any particular topics that I touch on today. Now, when we talk about health insurance, I often feel like I have to start with the very basics of building blocks, because understanding health insurance requires that you understand the words that are being used when we talk about health insurance. The challenge is it's like learning a new language that nobody's ever taught. I often say there should be a class in high school on health insurance and finances, because we all need to be able to how to figure out these things, but no one ever teaches us. I've known this anecdotally for years doing this work, but now we have quite a bit of research that backs up this assumption that people really don't understand the terms. In fact, in this one study, only 4% of Americans could identify the four most common terms used in health insurance. So it stands to reason, if people don't understand the words that are being used, how could they possibly be expected to pick the right health insurance policy for them? So I'm going to start by going through those basic terms that only 4% of Americans know related to the costs of health insurance. So the premium is something that we have to pay each month just to have health insurance. And you're going to pay this whether you go to the doctor or not. It's very similar to having car insurance, but never getting into an accident or filing a claim. But then there are some other costs that you have to pay when you actually use your insurance and go to the doctor. Your deductible is the amount that you have to pay each year out of pocket before the health insurance policy starts picking up their share of the cost. Now, their share of the cost is referred to as cost share or co-insurance. One of the reasons I think health insurance is complicated is that there are multiple terms for exactly the same thing. So when we're talking about cost share or co-insurance, this is a percentage, and it's what you pay each time you get care. So for example, if you have an 80-20 plan, it means once you've met your deductible, the insurance company will start picking up 80% of your healthcare costs and you're responsible for 20%. Many policies also have an additional payment called a co-payment. This is a fixed dollar amount that's going to depend on the policy and often on the service. So for example, it's common to have a policy that has a $25 copayment to see the doctor, or a $35 copayment to see a specialist, or a $250 copayment to go to the ER. Perhaps the most important thing for all of us to understand about our policies is the out-of-pocket maximum, because the out-of-pocket maximum is in theory the most that we are going to pay out of pocket for our healthcare per year. The out-of-pocket maximum is a fixed dollar amount, and it's going to depend on the policy. So the way that you reach the out-of-pocket maximum is a math problem. So you add up everything you pay towards your deductibles, everything you pay towards your co-payments, and everything you pay towards your co-insurance. So it's everything you're paying out of pocket except those monthly premiums. Now, the devil's in the details here. Typically, policies will only count payments made towards in-network providers to that out-of-pocket maximum. And some employer policies could carve out certain things from the out-of-pocket maximum. For example, they could say the deductible isn't going to count towards the out-of-pocket maximum. So you do have to understand exactly how your health insurance policy calculates the out-of-pocket maximum, but I want to give you a simplistic example of how this all works. So you have a health insurance plan with a $2,000 deductible. It's an 80-20 coinsurance and an $8,000 out-of-pocket maximum. You haven't used healthcare yet for the year, but you get into an accident and end up with a $102,000 hospital bill. What do you actually have to pay? The first thing you always have to pay is your deductible. We subtract that from the overall bill, which leaves $100,000 left. You have a coinsurance amount of 20%. 20% of $100,000 is $20,000. But do you have to actually pay $20,000? The answer is no. Because of that out-of-pocket maximum, you only have to pay another $6,000 because you've already paid $2,000 in your deductible to reach that $8,000 out-of-pocket maximum. So I'm not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start looking at the alternatives of what someone would have to pay without an out-of-pocket maximum, which here would be $22,000, or what someone would have to pay without health insurance at all, which would be $102,000, that $8,000 starts to feel a little bit more reasonable. It's also really valuable because as consumers, we can start to plan around a worst case scenario. This is also going to become really important at the end of the hour when we come back to how to pick a plan. Now, if you would like to hear any of that again in terms of the terms I described or this example, or you think there are people in your life that need to hear it again, loved ones, patients, coworkers, all of that is included in one of our animated videos on health insurance basics, and it's available in English and Spanish as well. So there are 3 places where we as Americans get our health insurance in this country. The largest number of Americans get their insurance through an employer. The next largest group gets their insurance through the government, primarily through Medicare and Medicaid. And the smallest number of Americans go directly to an insurance company for their health insurance. So it begs the question, if the largest number of Americans get their insurance through an employer, what happens if they have to leave their job, let's say for cancer treatment? COBRA is the federal law that allows eligible employees to keep the exact same health insurance policy that they had when they would normally lose it. In order to be eligible for COBRA, you have to work for a private employer with 20 or more employees. Now, the upside to COBRA is it's the exact same policy. So same network of providers, same prescription drug coverage, same payments. The downside is that it can be expensive because now you as the employee are responsible for 100% of the premium, plus sometimes a 2% administrative fee. So it can feel very, very expensive. The amount of time that you get to keep your COBRA coverage is going to depend on your qualifying event. So if you've left your job, or even if you've reduced your hours, and maybe you've gone from full-time to part-time and your employer doesn't offer benefits to part-time employees, you would generally be able to keep COBRA for up to 18 months. But let's say instead the qualifying event is a divorce or aging out of a parent's policy. Then the dependent would be eligible for COBRA for up to 36 months. Now, I say generally because there are 2 times when COBRA can actually last longer than that 18 months. And the first is particularly relevant for the cancer community in that if someone is deemed to be disabled by the Social Security Administration within the first 60 days of electing COBRA, they can get an 11-month extension for a total of 29 months, which helps bridge the gap until somebody's eligible for Medicare. So I know that this is sort of in the weeds, but more information about COBRA and this disability extension is available on the Triage Cancer website. There are also a handful of times when COBRA is going to end early. So certainly if the employee doesn't pay the premiums or commits fraud, COBRA could end early. And it doesn't trigger an opportunity to purchase a new plan in the marketplace. Also, if the employer stops offering health insurance to all employees or goes out of business, then COBRA would end because it's the exact same health insurance policy. And so if that policy doesn't exist anymore because the employer doesn't exist, there's nothing left for you to keep. In those circumstances, it would actually trigger a special enrollment period for someone to be able to pick up a marketplace plan. Typically, someone has 60 days from their qualifying event to elect COBRA. But right now, we are in a period that's referred to as the COVID extension to the election period. And I want to just bring this up because if you, or for the healthcare professionals on the line, your patients were eligible for COBRA, but maybe missed their deadline and want COBRA, they might still have the opportunity, which is unique to this year. The other piece that's really important to understand about COBRA is that the employee and the employee's dependents can make separate COBRA decisions. And here's where this can be really important. Let's say the employee is the one with a cancer diagnosis and wants to keep their exact same health insurance policy because of the network of providers. Maybe they've already met their deductible or their out-of-pocket maximum for the year. So knowing that all they have to pay for the rest of the year are those monthly premiums, but it's expensive. So in that situation, the employee could just take COBRA, and then the family members could potentially go and get a policy from the marketplace, for example. More information about COBRA available in our quick guide to COBRA on our website, and also on we have another webinar that explains COBRA in great detail. Now, I mentioned that in order to be eligible for COBRA, you have to work for an employer with 20 or more employees. So that leaves out a lot of people who work for smaller employers. For those individuals, I would recommend looking to see if their state has a state COBRA statute. The details definitely vary state to state, but they cover those smaller employers. And if you work for an employee or between 2 and 19 employees, you're not going to be looking at COBRA, you're going to be looking at the state law. To find more information about what's available in your state, you can visit our charts of state laws on our website under health insurance. Now, there's been a lot of discussion about healthcare reform over the last, 4 decades. And there's a lot of misinformation and confusion as to why we even needed reform. When we look at the healthcare and health insurance industry prior to 2010, there were 3 major barriers to accessing health insurance. The first is that it's confusing. So as we mentioned, even the words that are being used are confusing, but the options are confusing. How do people figure out what's better for them? When you put health insurance into Google, which is the thing that answers all of our questions, you get back 1 billion hits. So that's not actually helpful to someone trying to figure out what their health insurance options are. Another issue was that if somebody had a pre-existing condition, it was very challenging to find health insurance on their own. And even if they could find it, they were probably going to get charged a huge amount. Finally, what we saw over the course of a decade between 2000 and 2010 was that every year, the cost of health insurance was increasing, but the quality of the policies were decreasing. So all of that set the stage for the passage of the Patient Protection and Affordable Care Act, otherwise known as the ACA or Obamacare. And this law was signed on March 23rd, 2010. And I have to tell you that here we are over a decade later, and there's still so much confusion about this law. Part of it is that it's a huge piece of legislation, and it really touches every aspect of our healthcare system. So today, I'm really just going to focus in on the new consumer protections it gave us and the new health insurance options it gave us. So prior to the ACA, health insurance companies routinely would wait until somebody got sick and then look back in their original application for any mistake or omission they may have made on that application, even if it was accidental. They would use those as a reason to cancel the policy, because now that person has a pre-existing condition, they were essentially left uninsured. So the ACA said insurance companies can no longer rescind or cancel somebody's policy unless they can show fraud or that that person was really a bad actor. The ACA also addressed the issue that many policies had limits on the amount that they were going to pay for somebody's healthcare. Now, insurance companies can no longer impose lifetime or annual dollar limits on something called essential health benefits, which is 10 categories of care that most of us think that our insurance should cover. Prescription drugs, outpatient care, maternity care, mental health care, ER visits. So no more limits on those things. The ACA also addressed the issue that young adults were chronically uninsured in this country. And so it allows young adults up to the age of 26 to stay on their parents' policy. And this is pretty significant because the young adult could be married, the young adult could have their own children and still manage to be on their parents' plan. The ACA also tried to address the issue around when people entered clinical trials, their health insurance policies would basically say they were hands off at that point, that they weren't responsible for paying for any of the person's care at that point, which would cause a significant challenge to participating in clinical trials. So the ACA said that even if somebody's in a clinical trial, the health insurance policy is still responsible for covering the routine costs associated with care. So basically, what they would have paid for outside of the clinical trial, they're still responsible for if somebody's in the clinical trial. This was state law in many states prior to 2010, but the ACA made it federal law. And then the ACA also addressed the issue that there were some really significant barriers for people, even people who had health insurance, to access preventative services. So the ACA said that for a certain list of preventative services, the insurance company can't charge copay, can't say that somebody has to meet their deductible, and can't charge a coinsurance. So the preventative services are really free to access. And where we saw that being a problem was someone would say to us, I need to get my mammogram, but I have a $5,000 deductible and I can't afford to pay for that out of pocket just to go get the mammogram. So this provision eliminates that barrier because we know that access to preventative services is actually good for society in general. There are all sorts of other types of consumer protections that the ACA gave us, but those are really some of the most significant for the cancer community. The ACA also ensured that as consumers, if we receive a denial of coverage, we don't have to take no for an answer. And I mean that when we receive a denial of care, we generally have at least 2 opportunities to appeal that denial. Now, the details definitely vary on the type of insurance, but generally speaking, the first level of appeal is where you go back to the insurance company and ask them to reconsider. It could be that you're going to add additional medical evidence. It could be that you're correcting a mistake, but you're going back to that company. If you are still denied in the internal appeals phase, now we have the opportunity to get an external appeal or an independent medical review. This is going to depend on the type of insurance and the state, but generally speaking, we're talking about an independent entity that's going to look at the evidence, look at the insurance policy, look at the medical necessity, and decide whether or not the insurance company should have covered it. I fully appreciate that the appeals process is another burden that's being placed on patients and patients' families. That being said, we know that somewhere between 40 and 60% of all appeals are decided in favor of the patient. So when we're talking about financial toxicity and we're talking about access to care, this appeals process is incredibly valuable. It's also wildly underutilized. So somewhere between 0.5% to 0.2% of appeals or of denied claims are ever appealed. So less than 1% of denied claims are ever appealed. And when we know that roughly 50% of the time the insurance company is getting it wrong when they're saying no, it shows us that a way to combat the financial toxicity and the high out-of-pocket costs that people are paying is to go through the appeals process. If you are interested in learning more about the specific appeals process for the different types of health insurance, at triagecancer.org, we have a tool called Cancer Finances. And if you go to the appeals section of Cancer Finances, it asks questions. And the very first question is, what type of health insurance are we talking about? And based on the answer to that question, you're going to be sent to the relevant information. So definitely for the patients and caregivers on the line today, if you receive a denial, check that out. But certainly also for the healthcare professionals, if you're trying to help your patients through the appeals process, there might be some valuable information there for you. And then the last two consumer protections that I want to talk about are perhaps the most significant. And really, if the ACA did nothing else, I would still call it a win for the cancer community because of these two provisions. So the ACA said that health insurance companies can only look at 4 things when they're deciding how much they're going to charge someone for health insurance, that premium. So they can look at, is someone buying an individual or a family plan? Of course, family plans will be more expensive. Their geographic location, which is going to be based on zip code. Someone's age. So yes, the older somebody gets, the more they can be charged, but there's now a cap on how much more they can be charged, whereas before it could just be any amount the insurance company wanted. And then in most states, if somebody uses any form of tobacco, they can also be charged more. That's it. So what you don't see in this list and what insurance companies can no longer take into consideration is pre-existing conditions, health status, and gender, which are all things that significantly increased the amount that people would have to pay for health insurance. But then the ACA went one step further and said insurance companies can no longer deny selling somebody a policy based on a pre-existing condition or deny covering services related to a pre-existing condition. I have to tell you that I've been doing this for quite a while now, and I never thought that we would get to a point in this country where this was law. And here we are. This has been challenged over the last several years, but earlier this year, we did get a Supreme Court decision that sort of solidified that the ACA is here to stay, and this will continue to be law. Now, in terms of options, because now insurance companies can no longer deny selling somebody a policy, we have more options than we've ever had before. And sometimes the appropriate option for us is going to depend on our circumstances. So for individuals who have lower incomes and low asset levels, which are things like retirement accounts or savings accounts or a life insurance policy, prior to 2014, the option was Medicaid. But it wasn't just about low income and low assets. They also had to be able to walk through one of these 4 doors. And in the cancer community, most often where we saw people entering the Medicaid program was through this door on the left, through the age, blind, and disabled program. But there were some significant challenges with this. First of all, if someone just had a low income because they were no longer able to work due to a cancer diagnosis or treatment, but maybe had savings or a retirement account or a life insurance account, they literally had to spend all of that in order to access this program. The other challenge is that through the Age Blind and Disabled program, it's the highest level, it's the highest definition of disability that we have, because it matches the Social Security Administration's definition. So there were some real significant challenges to accessing Medicaid prior to 2014. The ACA tried to address that by creating a fifth door of eligibility that was just based on income. So they don't look at asset level, they don't look at disability status or age, it is just based on income. Now, the original 4 doors still exist and still have that income and resource level test. It's just that it added this 5th door. Now, for some people, there might actually be more than one door they can walk through. So thinking strategically about which is the easiest door to walk through can be really useful. It's also helpful to understand this because while the ACA intended this 5th door to exist in all 50 states, the Supreme Court got their hands on the law in 2012 and ended up making it voluntary for states to expand their Medicaid program. And this is where we are today, with 39 states or 38 states in DC expanding and 12 not expanding. The states on the right represent somewhere between 3 to 5 million people who would have had access to Medicaid if their states had expanded, but currently don't have that access. I will also tell you that this is the slide that probably changes most frequently in the slide deck, because as there are elections and voter propositions, states sort of move back and forth between these columns. And that's what all the different footnotes down here indicate. So it's all the states that ended up expanding after the original expansion period. This is also one of those places where I mentioned there's some advocacy opportunities. Now, a lot of times people will say to me, well, I get insurance through my employer, why do I care if my state expands Medicaid or not? And it's a fair question. And when it was first expanded, we had our suppositions as to how it was going to impact, but now a few years later, we actually have some data. So certainly there's the sort of humanitarian component that this program helps provide coverage to some of our population's most vulnerable, seniors and children and individuals with disabilities. But even above and beyond that humanitarian piece, there's a strong financial piece to it as well, because we've seen that the costs for health insurance for everybody in states that have expanded have gone down. We also know that in states that haven't expanded their Medicaid programs, they have the highest rates of uncompensated care in hospitals. So basically, this is where people are showing up to the ER and they don't have insurance, but the hospitals have to treat them. And when hospitals have high rates of uncompensated care, sometimes it ends up being that they have to close departments in that hospital to save money. And the most expensive department to operate is typically the emergency department. So if you have the best health insurance available to you and you get into an emergency and you go to the closest hospital and that hospital no longer has an emergency department because of the high rates of uncompensated care, that impacts you. So we often think about these policy decisions in a vacuum, when in reality, we have to step back and sort of look at it big picture, because there really is typically a domino effect, and Medicaid is a perfect example of that. So Medicaid is one of the major government programs I mentioned. The other is Medicare. So Medicare is the federal insurance program for individuals who are over the age of 65, or people who are under 65 but have been receiving Social Security disability insurance payments for 2 or more years. Medicare is complicated and complex, and I can't possibly do it justice in the time that I have today. So I'm going to give you sort of the 50,000 foot view of it and then point you to places where you can get more details. Although we talk about Medicare as being one health insurance option, it's actually broken up into 4 different parts. And each part covers a different thing. So part A is hospital insurance. Typically, when people are working and paying into the system, they're going to end up with Part A being premium free. Part B is medical insurance. And so Part B is going to cover things like doctor's visits and immunizations and scans and tests and IV chemotherapy, all covered under Part B. Even if you've worked and paid into the system, there is a monthly premium for Part B and an annual deductible. Now, Part A and Part B, when talked about together, are referred to as original Medicare, because when Medicare was passed, it's the only thing that existed. Prescription drug coverage through Part D was added in 2003, and Part D plans are sold by private insurance companies. So the amount that you are going to pay for Part D is going to vary company to company. Now, it turns out that potentially having 3 different premiums and 3 different deductibles and 3 different co-shares is a lot. So an alternative can be found in Part C, otherwise known as Medicare Advantage plans. These are Medicare plans that are sold by private insurance companies, and they are managed care plans, which means they're going to be PPOs or HMOs. They're going to have a smaller network of providers. There's going to be some additional rules. The costs are going to vary, but typically they're going to bundle all of the services you would get under Part A and Part B, and many of them include prescription drug coverage as well as some other types of services like transportation help or wellness benefits. When we talk about the major differences between Original Medicare and Part C, Original Medicare is what's called fee for service, which means you can go to any provider around the country that accepts Medicare and receive services. As I mentioned, Part C is managed care, which means you can only go to providers within that policy's networks. The other significant difference is Part B has an 80-20 cost share with no out-of-pocket maximum. So it can be very challenging to have that 20% and see no end in sight, particularly if you're getting expensive treatment. Part C plans do come with an out-of-pocket maximum. So when we're thinking about our Medicare options, really there's 2 lanes to drive in. The first is Original Medicare, where you pick up Part A for your hospital insurance, Part B for your medical insurance. You decide if you want prescription drug coverage, which I hope the answer is yes, and you pick up a standalone Part D plan. But remember that 20% that comes in lane 1, that 20% coinsurance? The way to protect yourself from that being open-ended is by purchasing an additional insurance policy called a Medigap policy, also known as a supplemental policy. And these, again, are an additional policy that you purchase, that many of which will cover the out-of-pocket costs that are associated with Parts A and Parts B. So that's lane 1. Lane 2 is Medicare Advantage, where you're going to a private insurance company and purchasing a managed care plan that will bundle all of your Part A and Part B services underneath that umbrella. And if you pick one of the ones that doesn't include prescription drug coverage, you can then pick up a standalone Part D plan. But that's where it ends in lane 2, because lane 2 comes with that out-of-pocket maximum. Now, as I promised you, I know that was really fast. Please, 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 if you are Medicare eligible, or if you are helping patients who are Medicare eligible, take a look at our existing resources. We have a 90-minute webinar. We've got quick guides, which are downloadable documents from our website. We have a module on cancer finances, and we even have 4 different animated videos that talks about the different pieces, including how to pay for Medicare coverage. And these are available in English and Spanish and have closed captioning. We are coming up on Medicare open enrollment starting on Friday. So this is particularly relevant right now in this time of year. So we've talked a little bit about employer coverage and government coverage, and I want to switch gears to those people who are at the top of the triangle and purchasing insurance from an insurance company. The Affordable Care Act created something called a state health insurance marketplace. And these marketplaces are like health insurance shopping malls or Amazon for health insurance. What you are purchasing in the marketplaces is a policy from a private insurance company, Blue Cross Blue Shield, Humana, Aetna. It's just that the marketplace provides you with the infrastructure to go in and buy the plan. There is a huge misconception. Lots of people think that this is government insurance. It is not. So it comes up a lot where people ask me, well, wait a minute, if I'm buying a policy from a private insurance company, why do I need to go through the marketplace? Why can't I just go straight to the insurance company? And you can, but there are some significant advantages to going through the marketplace. First of all, there's some quality control because the plans sold in the marketplace have to meet minimum standards in order to even be able to walk in the door. There are also caps on the out-of-pocket maximums for plans sold in the marketplace. So for this year, the out-of-pocket maximum for an individual can't be more than $8,550. Again, we talked about how that is definitely a lot of money, but if you remember back to my example, it's certainly better than not having a cap at all. In addition to the cap on the out-of-pocket maximums and the quality control, there may be financial assistance to purchase plans in the marketplace. And there are two different types of financial assistance. The first is a premium tax credit, which is going to reduce the amount that you pay monthly to purchase your insurance. The second type of financial assistance is a cost-sharing subsidy or a reduction. And this type of financial assistance is going to help reduce things like your deductible or your copayments. The other really helpful thing about plans sold in the marketplace is that they all fall into one of these different categories based on cost share. As a reminder, cost share is the difference, the percentage difference between what you have to pay for your healthcare and what the insurance company has to pay. So bronze plans have a 60-40 cost share once you've met your deductible. Silver or 70-30, gold or 80-20, and platinum or 90-10. Typically, bronze plans are going to have the lowest monthly premium, but the highest out-of-pocket costs, whereas platinum plans are going to have the highest monthly premium, but the lowest out-of-pocket costs. So what's really useful about this system is that we can now shop for health insurance the same way we shop for so many other things nowadays. So maybe I'm super healthy. I rarely go to the doctor except for my annual checkup. So I don't really want to pay that much. Only show me the bronze plans. Or conversely, I have a cancer diagnosis and I feel like I'm at the doctor every 30 seconds and I want to make sure that I'm covered at as high of a rate as possible. Only show me the platinum plans. Or of course, somewhere in between. So just like on Amazon, when I only want to look for black sweaters, I don't have to sort through the other colors. It's the same concept here. So here's how the financial assistance breaks down, because it is based on household size and income level. In states that have expanded Medicaid, so all those states that I showed you on the chart on the left, if someone has an income at or below 138% of the federal poverty level, they would have access to Medicaid. If somebody has an income between 138 and 400% of the federal poverty level, they would have access to that premium tax credit. So reducing the amount you're going to pay monthly. And that's for any level of plan that they purchase. If people are choosing a silver level plan and they have incomes between 138 and 138 and 250%, then they would also be entitled to that cost sharing reduction or cost sharing subsidy to reduce things like copayments and deductibles. In states that are not expanding Medicaid, it's slightly different because Medicaid is off the table. So the amount or the federal poverty level percentage for the cost sharing subsidies goes down to 100%. The reason that isn't actually all that helpful is it's the premium tax credit that helps someone purchase the policy. The cost sharing reductions are only useful once somebody has the policy. So unfortunately, we do see a disparity or a gap in those states that haven't expanded Medicaid, because we have a situation where someone who's making over $50,000 a year gets help to buy health insurance, but someone who's making $15,000 a year doesn't get any help. Now, when we talk about financial assistance, there are some details that are valuable to understand. So when you go to the marketplace and you put in the income, you are projecting your income for the year ahead. It is very helpful to be as accurate as possible, because if you end up making more than you estimated, you'll actually have to pay back some of that financial assistance come tax time. But the good news is the marketplace recognizes that things change in the year. And so if something changes, like let's say you get a job and now your income is going to be a lot more, you can report that change to the marketplace and your financial assistance will be adjusted for the year, the rest of the year, and you won't have to pay any of that back. Now, I do also just want to mention that we have some late breaking news related to COVID, but you don't have to have been impacted by COVID to benefit. There has been some additional financial assistance added to the marketplaces for this next year. And for people who have incomes between 138 and 150% of the federal poverty level, they will qualify for a marketplace plan for $10 or less a month. If you know people who are uninsured because they think they can't afford a policy, it is worth their while to check in the marketplace. We also have additional help for people with incomes over 400% if the amount that they're paying for health insurance is over 8.5% of their income. So I really just want to mention this, that, you know, we hear from people, particularly as we are coming into open enrollment, oh, I looked in the marketplace and it was too expensive for me before. Things are changing, so it is worth a second look now. We also get questions from people about if they have employer-sponsored health insurance, can they purchase in the marketplace? And the answer is absolutely. We aren't required to take our employer insurance. But typically, if you're offered employer insurance, you're not going to have access to that financial assistance. There's some exceptions here that I've listed on the slide, but the general rule of thumb is you can buy a plan if you have employer-sponsored insurance in the marketplace, but you probably won't be eligible for financial assistance. So what all of this comes down to now is if someone experiences a life-changing event where they are going to lose their health insurance coverage, they actually have more options than they've ever had in the past. So they could pick up COBRA or State COBRA to keep the exact same policy they had. They could purchase a new plan through the marketplace special enrollment. They could maybe go on another group plan like a spouse's or a parent's plan, or potentially they could be eligible for Medicare or Medicaid. But the trick with this is they have to pick a lane and stay in it. They don't get to change lanes until the next open enrollment period. Now, when somebody's interested in looking at the marketplace, they can go to healthcare.gov or the state marketplace, because the online system does provide some extra tools, but it's not the only way people can access it. So there is a phone number or a toll-free hotline. When someone can enroll is going to depend on the type of coverage we're talking about. So Medicaid applications are accepted year-round. As soon as somebody becomes eligible, they can apply. Employer plans are going to vary, but many employers will choose a fall open enrollment to coincide with the January 1st start date. Medicare, as I mentioned, open enrollment starts on October 15th and will go through December 7th. And marketplace plans start on open enrollment starts on November 1st and goes through January 15th of 2022. Medicare plans and marketplace plans are calendar year plans. So even if somebody picks up a plan on the first day of open enrollment, the soonest it can start is January 1st. Fortunately, if somebody has a life-changing event outside of open enrollment, both the marketplaces and Medicare have special enrollment periods where you have 60 days to pick up a new plan. So what's great is we have all these options now, but how do we make choices between the options? I'm going to give you an example using the marketplace, but the same analysis works whether you're trying to compare a marketplace or employer plans, or do I take an employer plan or a marketplace plan, or even if I'm trying to compare my Medicare Advantage plans. So I went to healthcare.gov/cplans and was able to put in some information and narrowed it down to these 3 different options: a bronze plan, a silver plan, a gold plan, different premiums, different deductibles, different out-of-pocket maximums. How on earth am I supposed to figure out which plan is going to cost me the least by the end of the year, assuming that I'm going to hit my out-of-pocket maximum, which is a pretty safe bet when we're talking about cancer care and cancer treatment. So I can't tell without doing the math. And the way you do the math is you take that monthly premium and you multiply it by 12, because that's how much you're going to pay in premiums for the year. And then you add the out-of-pocket maximum. And when you do that for all 3 plans, you can see that the gold plan with the almost $400 a month premium actually ends up being the cheapest. Now, there isn't a huge difference between the bronze and the gold. So why might someone still want to take the gold? Well, certainly the gold is a POS plan, which could have more providers than an HMO. But also the deductible is only $1,000. Whereas with the bronze plan, you would have to pay $6,000 out of pocket before it even started picking up 60% of your healthcare costs. So while we think it's really important to do the math and figure out that worst case scenario, how much would I pay at the end of the year, that's not the only thing we need to be looking at. You need to understand if the networks of doctors and providers that you're seeing are covered, if the prescription drugs you're taking are included, and the marketplace gives us some tools to do that. And this is one of the examples as to why I think the website can be really useful. But of course, picking a health insurance policy is only half the battle. Once we have the policy, we have to make sure that we're using it effectively. And that means using in-network providers whenever possible, asking for prior authorization, certainly paying attention to bills and appealing denials of those bills, and then potentially leveraging out-of-pocket maximums. So understanding the out-of-pocket maximum can help us understand that if we need other medical care in the year, get it this year. Don't wait until January when everything starts all over again. It can also be really important when thinking about the timing of treatment decisions. If it's possible to get it all in a calendar year, that could end up meaning thousands of dollars in savings. So I see the question box ticking up. So I just want to mention that there are a whole host of things on the table in terms of advocacy opportunities, because there are still gaps in the law. So if you're interested in what those are, on the Triage Cancer website under our advocacy page, we have a bunch of different advocacy priorities listed so you can learn more. So the takeaways here are that you can't be denied health insurance or charged more because of a pre-existing condition. When weighing options, it is important to look at the math, appeal, and certainly keep staying abreast of the changes. We have that information on the website, as I've mentioned several times, plus the blog. The last thing I just want to mention is we recognize that sometimes people have questions where they need one-on-one help. Triage Cancer does have a legal and financial navigation program where you can fill out the form at triagecancer.org/gethelp and schedule a 30-minute call with one of our staff. We don't provide legal representation or provide legal advice, but we can provide you with information and answers to your questions. So with that, Nicole, I'm going to ask if you want me to take questions first or if you want to go through resources first.
Thank you, Monica. I think just real quick, I just wanted to go through a couple of things on our end, and then I see we have a ton of questions and everybody's, I'm sure, anxious to get them answered. So we will move on to that as soon as we can. I just wanted to point out a couple of our additional resources. Obviously, you know about our webinars. You are here today. We do have our West Coast Conference taking place this Saturday, October 16th. It will be virtual. Registration is still open. If you'd like to join us, we'd love to have you. We also have a resume review service, and additionally with Triage Cancer, we do offer in-service trainings as well. We have 2 remaining webinars in our Balancing Work and Cancer webinar series, Communicating Effectively on November 3rd, and then Newly Diagnosed Getting Started on December 9th. And additionally, here are a few of our recordings of our webinars, and just noted that all of our webinars will be recorded and stored on our archive on our website. So if there are any older ones that you weren't able to attend, please feel free to check those out whenever you'd like. And I'm just going to leave up our CEU requirements again while we move on to the Q&A portion. I know we only have a few more minutes left. We'll see how we're doing, and if we need to go a few minutes over, if everyone's okay with that, then we'll go ahead and do that.
Sounds great.
Monica, if you want to go ahead and start addressing that pile up that I'm seeing here.
Absolutely. Thanks, Nicole. I also just want to mention that Triage Cancer staff attorney, also named Nicole, is on today, and she's dropping a link to a resource document that has live links for all of the documents that I talked about, because I know it can be a little bit of a rabbit hole to try to find them. Okay, so how long does the open enrollment window stay open? It depends on the type of health insurance that we're talking about. So if you're talking about the marketplace, it goes from November 1st through January 15th. Medicare is October 15th through December 7th. Employer plans can vary. So it depends. Can you get healthcare.gov for 1 to 3 months to fill the gaps between leaving Medicaid and working full-time? Yes, and in fact, that's a really great strategy. If your income has pushed you out of Medicaid eligibility, but you're new because you've started a job, but maybe there's like a 90-day waiting period at your job before benefits kick in, getting a marketplace plan for that 3 months is a very good strategy. A person can be eligible for both the premium tax credit and the cost sharing subsidy, assuming that they're purchasing a silver plan and they fall into those income limits, because those cost sharing subsidies are only available for the silver plans. Is a marketplace considered healthcare.gov? Yes, it is. Now, I will say some states run their own marketplaces, so they could have a different website. But everybody can start at healthcare.gov, because the very first question that's asked on the website is, what state do you live in? And if you live in a state that has a state marketplace, the website will actually redirect you to the appropriate website for your state. With COBRA coverage, if an employee is eligible for Medicare, the dependent who's not eligible for Medicare can be eligible for COBRA for up to 36 months. That is correct. So if the employee becomes Medicare eligible, and now that means that the spouse is losing coverage, that's a qualifying event into COBRA to keep that employer plan for up to 36 months. That is exactly correct. If an insurance company can't deny you from purchasing a pre-existing condition, can they place a rider or exception of coverage for that pre-existing condition? Not if you are buying a comprehensive health insurance plan through the marketplace. There are some limited coverage short-term plans that don't have to comply with the Affordable Care Act. There are some association plans that don't have to comply with the Affordable Care Act where we see this happening, which is why, particularly for the people in the cancer community, a safe avenue is to go through the marketplace, because you'll know that what you're buying is a comprehensive plan that can't place those limitations. Do premiums ever count towards the out-of-pocket maximum? Never. It is never going to be included in the out-of-pocket maximum. There was a question to see the last screen again, but I'm sorry, I don't know what screen that was, but I do know that Cancer Careers sent out the link to the slide deck, so hopefully you have that. I'm concerned about the level of coverage offered by Medicare and Medicaid. Is it good coverage equivalent to good employer insurance? It depends. So Medicaid, while it's a federal program, is administered by the states. And so there is a lot of variation between the different states. Some issues with Medicaid can be providers. So not all providers accept Medicaid. With Medicare, it also depends. So which lane are you driving in? Have you picked up an Advantage plan or a Medigap plan? Margie, if you have specific questions about your situation, I would suggest that you fill out an intake form on the Triage Cancer website so that we could actually schedule a 30-minute call to get sort of more into the weeds of your situation. If someone's offered COBRA, does this typically include dental vision plans in addition to medical plans? It can, yes. Depends on what's offered by the employer. There's a question about income, and I'm not 100% sure when this question came in and what I was talking about when it came in. So I don't know how to answer that question without more details. If we're talking about for the financial assistance in the marketplace, it is the modified adjusted gross income, which is a pretty complicated math problem to figure out, but we do have that information on our website on the quick guide to marketplaces. So hopefully that answers. There's another question about fertility preservation that's pretty specific, so I'm going to refer you to the navigation program as well. So there's a question about if we help patients navigate insurance options. We definitely do provide people with information about their options and can give them information about how to weigh the pros and cons. We do not help people fill out applications or tell them pick this over this. We just don't have the capacity to do that piece, but we certainly hope that by providing the information, then patients can feel empowered to take the appropriate next steps for them. I'm on long-term disability, still employed and receiving healthcare through my employer. Can my employer terminate me during this period? If so, what's my best option in terms of gaining healthcare benefits? In terms of if your employer can terminate you, it depends. So it depends about how long you've been on long-term care and employer policies. So we'd need more details to be able to kind of answer that more definitively. In terms of healthcare options, again, it depends. So certainly you would have to go through that analysis if you're eligible for COBRA or if a marketplace plan would work. If you're receiving SSDI, are you eligible for Medicare? So I'm going to say fill out a form on our website and we can give you more details. Nicole, I feel like you can just cut me off when it's time to go.
Yeah, it's 5 minutes after the hour, so we have another minute, so maybe another question.
Perfect. So there's a question about how long someone can keep COBRA for. Excuse me. If we're talking about federal COBRA, so for employers, excuse me, with 20 or more employees, it is not dependent by state. It's dependent upon qualifying event. If you are looking at the slide that shows the different states, then it is up to the state because those are state COBRA laws, and that's the information that you can find on the chart of state laws. So it really depends on the size of the employer to figure out which one you're going to be looking at. So for any questions that I didn't get to today because of time, I apologize. I hope you have found it useful, and certainly feel free to check out those resources at triagecancer.org. And for specific situations, you can certainly fill out the intake form on our website and schedule a 30-minute call with us. So thank you all so much for being so engaged and asking great questions.
Great, and thank you so much, Monica. Obviously, your insight is so valuable, and based on the number of questions that we got today, I feel like you were able to really address a lot of concerns that people have about insurance that remains a total mystery to me as well. So thank you again for joining us. Thank you all for tuning in today. I hope you found this webinar helpful. We'll be emailing the online evaluation tomorrow before 5 p.m. We really do appreciate your time filling this out so that we can best develop this program to meet your needs. And it's also very helpful in shaping future calls and keeping the funding coming in for these kinds of programs. As Monica mentioned, if we were unable to get to your question today, please feel free to email us and we'll be sure to get that answer for you. Thank you again to Monica, and I hope you all have a wonderful rest of your day.